Okay, well, thanks everyone. First of all, can I welcome Professor Alan Jackson to our meeting, and I welcome everyone that's joined the meeting. As you know, this is the HCC, or West London Sickle Hemoglobinopathy Coordinating Center group, and we organize these educational events periodically, looking at issues and subjects that are relevant to our thalassemia to our sickle population particularly. So we all know and we believe that obviously diet and nutrition is an important aspect of people's lives. That's why we thought it would be quite useful to have a lecture from Alan about diet and nutrition. First of all, can I ask anyone who's not speaking to please mute your microphone? And I think it'll be quite useful when Alan is speaking to, if we can also maybe hide our videos so that we don't have distraction in people's rooms and what have you. Okay, so let me, without further ado, let me introduce Professor Alan Jackson, who's Emeritus Professor of Human Nutrition in the University of Southampton. He's a convener of the International Malnutrition Task Force and the International Collaboration on Nutrition in relation to cancer. As director of the Tropical Metabolism Research Unit of the University, he carried out studies with the MRC Sickle Cell Unit. And as we all know, that MRC headed by, at the time, Graham Sargent was in Jamaica for many, many years and produced a lot of the materials that we use to determine care and management of sickle. So with the MRC Sickle Cell Unit, it characterized changes in energy, protein, and amino acid metabolism in sickle cell disease. He's been in Southampton since 1985, established the Clinical Nutrition Support Team, and was the director of the NIHR Biomedical Research Center in Southampton, with special capability in translational nutrition research. So I don't think we could come, with anybody better qualified in relation to diet and nutrition and sickle cell disease than Alan. So I welcome you, Alan, and thank you for your agreeing to do this presentation for us. Over to you.
Thank you very much, Lola, for the kind introduction, and to Ralph for working the visuals. Good afternoon, everybody. It's always a little challenging in a talk like this to know exactly where to start, as I've no idea who I'm talking to. So forgive me if I start off with things that are very familiar with you, but sometimes things that appear familiar aren't always so. So my first slide, if I may, Ralph, is simply to establish what my understanding is of health and how health is achieved. And in nutritional terms, this is about the flow of energy and nutrients through the body. And the remarkable thing is that if you think of all the food you've consumed over the last year or 2 years or 5 years, despite all of that, you've remained with a fairly constant weight and body composition and reasonably good health in terms of cellular integrity and capability. And this goes together with functional capabilities marked by body defenses, inflammatory and immune function, physical performance, mental, intellectual, and social function. And if you're a child or an adolescent or a pregnant woman, you look to gain tissue, deposit tissue as part of your normal physiological state. So that is the ambition, that is what we're looking to achieve when we think about diet and nutrition. Next slide, please. And so what I'd like to do in the next few minutes is present to you some basic nutrition principles, characterize some of the significant alterations in sickle cell disease, which I'm sure you're all very familiar with, and then against that to consider some care-related thoughts. Next slide. So the dynamism that represents health is a positive interaction that we all have with our environment. And for this purpose, that positive interaction is with fresh air, clean water, and wholesome food. You require those to remain healthy. The fresh air is, if you don't have fresh air, then you only have minutes to pass to exist, because it's central to energy generation. But there are also disadvantages because it's associated also with oxidant damage. Clean water, survival is a matter of days. And it's important, of course, because it maintains the circulation, but also particularly for the ability to excrete solutes and therefore maintain the cleanliness of the system. Wholesome diet, you're good for about 2 months, but the purpose of the diet is to meet the usual demand of the body for energy and nutrients. And in this context, we have to particularly consider the turnover of red cells and the stresses imposed upon both by those red cells and the red cells on the system, very much related to redox changes and associated inflammation and the predisposition to infection. Next slide, please. Now, it is unremarkable, but it's worth stating that everybody, all people, all patients need to receive adequate nourishment. And this is about the amount and the quality, but it's also about the regularity. You can't do it some days and then not bother about it for a week. It's not a sometime thing. It has to happen every day on a regular basis. And failure leads to increased vulnerability, and that's a risk in the short term of acute ill health or chronic ill health. There is a cost to not doing it. There's a cost in terms of your health, but also your livelihood, your progress, the quality of your life, your ability to engage in gainful employment and enjoy life. Next slide, please. So one of the particular points that I want to make is the relationship between diet and nutrition. Many people use the terms interchangeably, but for me, there's an important difference between the two. And this is a difference within a supply-demand relationship. The diet is a supply consideration. It's what the body is supplied with in order to meet a demand. The demand is what nutrition characterizes. So nutrition is about the demand, essentially the demand for energy and nutrients, the energy and nutrients that every cell in the body requires on an ongoing basis to enable the cells to function well, the tissues to function properly, and together in an integrative way to enable the body to function. As I've already indicated, normal growth and development are absolutely dependent upon that demand being satisfied. And certainly in this context of sickle cell disease, quite apart from the normal demands, there are also the demands imposed by added stress or stressors, which are an inevitable consequence of the shortened red cell lifespan and the sickling of cells within the circulation. And understanding those relationships is the key to the challenge that we are faced with. Next slide, please. So, is there evidence of nutrition-related problems in sickle cell disease? Well, of course there are. It's not that everybody experiences all of these, but as a pattern for the population, there's retardation in growth in young children, so there's a slowing of growth. There's a delay in adolescence. Adults tend to be thinner. There are metabolic changes in terms of the delivery of nutrients to tissues. If when looked for, it can be demonstrated that there are deficiencies of many nutrients. And a consequence of this is that those cells that the body depends upon to maintain its integrity, particularly the immune system and the ability to cope with external challenges, is compromised. Next slide, please. And so there is clear evidence for an impaired state, and let us look at that a little bit further. The nature of the demand and how best it might be met. So there are really two broad considerations that are separate but related. First of all, there's the consideration of the turnover of red cells. The lifetime of the red cell on average is 1/10 that in a person with AA hemoglobin. And the consequence of that is that you lose the red cells, you lose the contents of the red cells, and you lose the heme. Now, heme is a basic fundamental molecule, a very old molecule in biology, and it performs a wide range of functions within the system in terms of oxidation and reduction. The importance is that heme is an end product of metabolism, that when it is broken down, it is lost from the body, it is lost as bilirubin. And so the building blocks that go to make heme have to be provided on a constant basis. And therefore, and the major component that's required for this is the simplest amino acid glycine, which is required in very large amounts, much more than can usually be provided in the diet. So there is a challenge for ordinary people in making enough glycine available for this. This is even exaggerated even more in sickle cell disease. And then there's the sickling process itself and the consequences of that, both in terms of the circulation and the vasculature and the tissues that are served by that circulation. And there are clear descriptions of the many changes that take place and the problems that ensue as a consequence of this. Now, each of these changes and each of these alterations has a cost, and that cost ultimately is reflected in a consideration of a demand for nutrients that has to be provided. Can you go on, please? In clinical terms, obviously this represents manifestations of ill health, and depending upon the individual, it might be infection, skin ulceration, bone damage, clinical signs that you're very familiar with. And this of itself, because of the ongoing inflammation and stress, leads to depletion of any functional reserves that there may be, so that whereas under normal circumstances one has reserves to cope with times of stress, because individuals for whom there is a constant demand upon these reserves, the reserves are depleted, and therefore their resilience, their ability to cope with challenges is diminished. Next slide, please. So in nutrition terms, thinking about malnutrition, there are two processes that operate together but along separate axes. The first is a consequence of an inadequate food consumption, poor appetite or whatever, and this leads to wasting and a series of physiological changes characterized as reductive adaptation, where resilience is decreased substantially. Next, please. Along the other axis is a consequence of a stressor, a stress, infection, trauma, sickling. And here there is changes, important changes, where cells and the tissues are unable to retain nutrients in the usual way. And there are losses of nutrients from the cells and from the body. And the consequence of that is cellular damage and tissue malfunction. So for any individual who is challenged at any time, there is a mixture of these two processes going on, and the clinical challenge is to understand how those relate and how those can best be managed. Next slide, please. So in the face of any environmental stressor, in an individual who has reduced reserves, increased vulnerability, then any stressor, inflammatory challenge, infection, trauma, or toxic exposure adds to the already ongoing stress imposed by the sickling process and increases the likelihood of an individual expressing themselves as being unwell. Next state. And so there are a series of factors that one can measure in patients who have sickle cell disease. First of all, their general metabolism takes place at a heightened rate. There is increased protein synthesis, and this is in a way unremarkable because there is a need for increased protein synthesis to keep up with the rate at which red cells are being broken down. And that's associated with changes in bone turnover, sickling processes, and the inflammatory response. And so all of these increase the metabolic rate, and therefore the energy required to support the system is increased as a matter of course. And these are also associated with altered nutrient requirements. But it's quite difficult because when we do studies, when we do metabolic studies to characterize these changes, almost invariably they're done in individuals who are relatively well. It's very difficult to do these studies in individuals who are acutely sick, and therefore the changes that we measure are likely to be a least statement of the challenge there is, and that the chronic hypermetabolic state is indicative of an ongoing response to stress and the challenges to be able to meet that in a satisfactory way on an ongoing basis. Next slide, please. As a general statement, regardless of, for everybody, there is a general response to stressors, whether the stressor be a biological stressor such as a viral infection or a bacterial infection, or whether it's a behavioral stressor due to life choices in terms of smoking or alcohol, or whether it's a sociological stressor associated with heavy work or social deprivation, poverty. There is a general responses within the body marked by changes in inflammation and immune responses, and then the stress response itself, which is differentially characterized, but classically in the 30s identified by cellular as a whole body response integrated through hormonal systems, particularly the hypothalamo-pituitary axis. And the remarkable thing for him was that people who were unwell had common symptoms and signs related to being unwell, which didn't of themselves localize the disorder. Over the past 20 years, Helmut Zies and colleagues have focused on the cellular oxidant stress and described the mechanisms at a cellular and subcellular level which enable the system to cope with those stressors. And so there are general effects and general consequences. All of these carry a nutritional cost. Next slide, please. And so there are a cluster of changes which are well recognized to varying degrees in individuals who are stressed. There is an alteration in appetite and therefore a decrease in intake. There's an alteration in nutrient delivery to tissues of the body, cells and tissues, most obviously marked with the acute phase response, where nutrient transport proteins in the liver are downregulated in preference for acute phase reactants. So the usual nutrient transport proteins, such as the apolipoproteins or transferrin, retinol binding protein, are not available to transport the nutrients to the tissues, but the tissues themselves have altered nutrient demands. And so the overall balance in the body is changed. In addition to which, as I've stated earlier, there are increased nutrient losses So there are losses of nutrients from the body as a consequence of the stress. So if there is an individual is on a marginal diet before the stress comes along, and then they have the stress, simply going back to that marginal diet is not good enough, because they will already have a body deficit of those nutrients, and there's a need to make good those nutrients during the recovery period following the removal of the stressor. Next slide, please. And so what is the sort of advice or guidance that can be given to people in this situation? Well, the advice to individuals is the same regardless of their state. It's the advice to the population as a whole, which is the advice to maintain health in otherwise healthy people. And this advice is based upon what has been assessed scientifically as the dietary reference values, which is a need for energy and nutrients to maintain health in otherwise healthy people, on the assumption that all nutrient needs are met. And this is an idealized situation which scarcely exists. But in practical terms, the energy and nutrient advice is offered as food-based dietary guidelines, which I hope you're very familiar with. And the basic sense is that the diet should be diverse, it should be varied in composition and mixed, avoid or limit sugar, salt, fat, limit processed foods, which is demonstrably have a negative effect on health and many of the systems that I've been talking about, to limit meat, to limit red meat, and encourage the consumption of fresh fruit, vegetables, whole grain cereals. I don't think that there's anything novel about that, and I hope that not only are you aware of those guidelines, but that you practice them. Physical activity is clearly an important and integral part of health, an integral part of nutrition health, as is an adequate intake of water. Next slide, please. And so the question is, if we attempt to provide patients with sickle cell disease what we understand to be usual requirements, do they benefit? And the answer to that is, I think the evidence would suggest, although the evidence is not strong, it's mainly anecdotal and limited to this sort of study, which is now many, many years old, but the evidence that if care is taken with the dietary intake, then individuals can do well. It serves to ameliorate the challenges and improve the resilience of the individual. Next slide, please. But the quality of the evidence is poor. There are very few high-quality studies. There are very few studies which demonstrate, which show demonstrably the benefits or identify the limits of this approach. Next slide, please. There have been very, very few studies over the many years. And so the question remains, how do we address the problems associated with sickling? How do we address the problems associated with red cell production? How do we demonstrate the benefit, the problems associated with stress? Particularly redox perturbations. It's my understanding that one of the important benefits of hydroxyurea is that it operates through some of these mechanisms, even though understanding of how it operates specifically is not good. The fact that it does confer benefits in this regard, I think, adds weight to the argument that if we were better able to use not only hydroxyurea, but other nutritional approaches to improving these changes, then we would potentially be able to handle better inflammation, infection, and the consequent end organ damage. Next slide, please. Now, over the last little while, increasing emphasis has been placed on the role that gasotransmitters play, not simply in terms of oxidant damage, but also in terms of reactive nitrogen species and the damage they cause, reactive sulfur species and the damage that they cause. And I'd just like to make the point that whether one is talking about nitric oxide, which is generated in the body from arginine, which of itself is derived from glutamine, or hydrogen sulfide, which is a product of cysteine, which itself is generated from serine and glycine, or oxygen, which is managed importantly through heme, which, as I've already indicated, is formed from glycine, or glutathione, which is the main cellular antioxidant, which is derived from glycine, cysteine, and glutamine. What we are talking about is a series of amino acids which are called non-essential amino acids. They're called non-essential amino acids because they don't have to be provided preformed in the diet, because under usual circumstances, the body can make sufficient of them. In fact, the body has maintained the ability to make these amino acids because they are so fundamental to health, and they are required in large quantities to support these sorts of special pathways way beyond what can usually be achieved from the normal diet. And so there is this particular demand for conditionally essential amino acids, these conditionally essential amino acids. And one of the big challenges is to better understand how we can increase the availability of these amino acids to support the balance of gasotransmitters in an appropriate way under conditions of increased stress. One approach that people have adopted is to say, okay, well, we need more amino acids. Amino acids come as dietary proteins. We should give more dietary proteins. And that's a clear and seemingly sensible approach. But it's not that straightforward, because a high protein diet also gives a number of the so-called essential amino acids which are not required in additional quantities and which have to be lost from the body. If they're not lost from the body, then they produce toxic symptoms in their own right. We know this from inborn errors of metabolism. Inborn errors of metabolism, such as maple syrup urine disease or phenylketonuria, where there are problems in getting rid of those amino acids, which produce these massive toxic effects. Equally importantly, a number of the amino acids in their detoxification processes place demands on these same conditionally essential amino acids. And so rather than making it easier to have the conditionally essential amino acids available, they represent a competitive demand and reduce the availability of these amino acids for these critical functions. And of course, in order to do any of these things, there is a need for vitamins, minerals, trace elements which enable the intermediary metabolism. And although people in sickle cell disease with a low hemoglobin and anemia are quick to think about giving the obvious hematinics, they are slow to think in a wider sense about all the other nutrients, that are necessary but less obvious in their support of cellular function. And therefore, a complete demand, meeting the complete demand, is more than simply giving those things that are traditionally given as hematinics. Next slide, please. And so over the last little while, a number of basic scientists have been looking at this problem as a systems problem, looking at the way these complex systems operate together and developing models as to how they might better understand it in order to treat it. And in order to better appreciate the physiological and pathological changes colleagues of mine, have come up with this framework, which is gaining some attraction. Instead of simply talking about oxidants or reductants, have introduced a concept of the reactive species interactome, which is a much wider embracing consideration of how capabilities are integrated, and in this slide horizontally. So in the center of the slide, there are the reactive species, nitrogen, oxygen, and sulfur-based species. To the left are the metabolic pathways through which they are generated and enabled. And to the right are the effectors, the way in which they modulate metabolism at the level of enzymes or structural proteins, and to the far right, the biological effects that they have in the shorter or longer term. And clearly these are processes that take place at the cellular, subcellular, and local tissue level. Next slide. But they also have to fit in a hierarchical system within the whole body. And within the whole body, there is an integrated response which calls on progressively higher levels of organization to support in dealing with challenges. Much of the communication of this integration vertically, so that you can map the horizontal integration with the vertical integration, is carried out through communications through the circulation. And of course, this is a point where what is happening in sickle cell disease becomes particularly important. Next slide, please. In the context of the COVID epidemic, they have sought to put that together as a general statement about coping with stress. And here on this rather complex slide, there are just 4 snapshots of the sorts of processes that are important. On the left is a statement that depending upon the level of stress, then there is progressive recruitment of high levels of integration from local to whole body responses. On the next slide along, it looks at the issue of nitric oxide generation and the whole important role that that plays throughout the cardiovascular system and beyond, and simply notes the need for integrated engagement where glutamine, which is generated in muscle, passes to the gastrointestinal tract to be converted into citrulline, which then passes to the kidney for conversion to arginine, which is made available to the rest of the body as the source of nitric oxide. And perhaps one of the more important statements within this is that if you want more arginine because you have a greater stress or greater infection, then one of the ways that you have to make that available is through greater exercise. And so the reserve capability for supporting this system is a physical activity based consideration. In panel C, it simply looks at the nexus of the methionine remethylation and transsulfuration pathway, which links this critical point in metabolism whereby the hydrogen sulfide is generated but is locked into a wide range of other cellular events, including the capability for methylation of DNA, setting up epigenetic opportunities and so on. And then the last one simply addresses the question of glutathione, the major oxidant protection within the cell. And I've already mentioned that there is a need for this amino acid glycine to make glutathione. And we know that in sickle cell disease, the demands for glycine are greatly increased for heme formation, and that of itself challenges the availability for glutathione formation. And we know that in sickle cell patients, certainly those the most challenged, there is a limiting constraint on glycine for adequate formation of glutathione. And the purpose of this is simply to illustrate the complexity of the situation, to make the point that intervening with a single intervention at one point may or may not capture the issue that really needs to be addressed, and that in managing this nutritionally, there has to be a whole body approach. If I could take the next slide, please. And so the dietary guidance, which maintains health in an otherwise healthy people, is as good a way as any to approach the problem in those who are well. It's as good a way as any to approach the problem in people with sickle cell disease who don't have obvious added complications. The question is, what do we do when there are added complications? The next slide, please. And I think that this is where we are. So we have to consider food, nutrient, adequacy and security, and recognize the diet has two major considerations. There's a quantitative consideration and a qualitative situation. The quantitative situation is in terms of energy, and the qualitative situation is in terms of nutrients. The energy derives from macronutrients, carbohydrates, lipids, and protein, but the macronutrients also act as nutrients in their own right, together with minerals, vitamins. Go on with the slide, please. Vitamins, trace elements, water, and oxygen. And so the macronutrients fulfill a double purpose. They can do one or the other. They're expected to do both. And this has important implications for how one thinks about supporting people. Next, click on the next, please. Can we just go back? The amount of food that is consumed is determined by the amount of energy that is needed. The amount of energy, the demand for energy, is determined by the size of the individual and their level of activity. If you have an individual who is usually active or has a high level of activity, and they reduce their activity, they reduce their food intake because their requirement for energy is reduced. But in reducing their energy intake, they reduce their intake of all other nutrients. So if, when they were active, their diet actually wasn't particularly good, it was marginal in meeting the demands, then as they reduce their activity, that marginal diet becomes an inadequate diet and they fail to meet their demands. I've already talked about the implications of stress. On the one hand, there is a loss of appetite, so the quantity of food is reduced. And on the other hand, there is an increased loss of nutrients, so that the effective quality of the food is reduced. And so if you have somebody who is unwell and therefore is less active, has a reduced appetite and an increased loss of nutrients, then they are increasingly in a parlous state. They're in a parlous state over the course of that illness, but even more so when they recover, because they have lost nutrients from the body, and there is a need to make good those nutrients over and beyond what would normally be taken in order to get the individual back to a state where their resilience and their capability, their reserves are replenished. Next slide, please. So we need to manage the whole patient with the whole diet. We really do need to know the dietary intake that meets the metabolic demands within and across individuals, and to how best they can be met. Now, there is no way that we have of knowing how best to characterize that complexity. But what experience shows is that we can gain metabolic control by giving a diet that is sufficient in energy and meets all the other nutrients according to our understanding of requirements. And on that diet, individuals improve a great deal. The most recent example that I have had is in a study with patients with inflammatory bowel disease who have a tumultuous course. They get better, they get worse, they get better. And none of the doctors or dietitians looking after the patients could be persuaded that if their efforts were made to gain metabolic control along the lines that I have identified, there would be improvement. And they were resistant to doing it. Once we tried to do it, the remarkable thing was the enthusiasm of the patients for the diet. Their specific symptoms improved, their general feelings of ill health disappeared, their sense of fatigue disappeared, and they were very, very supportive of the activity. And we kept them on the diet until we had topped up their depleted reserves. We're waiting to see what the outcome of that is. But I mention it because of the dramatic nature of the response. And so the first question for me is there a need for a trial of a complete dietary intake in sickle cell disease? Or if you know of one, I'd be grateful if you could let me know. But my sense is that that is needed, and that in fact should be the baseline against which any other intervention is measured. Because to do an intervention without correcting these nutritional challenges will give very varied results, which are not interpretable because the baseline state from which you are putting in the intervention is so uncertain. Next slide, please. And so what of the future? I think there is the need for operational studies designed to characterize the variability and to determine patterns of growth and early problem identification, most simply as height and weight, but also more complicated body composition measures. There's the need to determine the nature and extent of specific nutrient problems, and that is possible. There's a need to determine the efficacy or the effectiveness of defined interventions along the lines that I've just articulated. And there's a need to define appropriate diet and nutrition care pathways that impact positively on growth, development, and complications of one kind or another. I don't know that any of those studies are being done. Next slide, please. There's also the need for basic studies which are designed to determine the basis of nutrient variability. And I've shown some of the complexities. All of those are capable of being interrogated and the points of vulnerability identified. We should have a better idea of the energy and nutrient requirements in a steady state and how that the nutrient state modulates different aspects of the gene expression that are so important in different phases of this disorder. We would really like to know the requirements during and after a sickling episode, and the requirements during and after a complication, not the sickling episode itself. And it would be really useful to know how these requirements vary with age, gender, functional state, such as infancy, childhood, adolescence, and pregnancy. I think much of these data can probably be collected out of routine care, if that is organized well and collected in an appropriate way. And it strikes me that it ought to be well within the capability of your network to make important progress in this respect. Thank you very much indeed.
Sorry, I was on mute. So, hi, Professor Jackson. I'm Matt. I'm one of the haematology consultants here at Period. I just wanted to thank you for that very comprehensive talk. and just showing how important nutrition and dietitian is in not just sickle cell management, but in just health in general, really. And I think it sort of fits in very nicely with all the sort of, the holistic approach to care of patients and sort of lifestyle medicine that is coming to the fore at the moment. I'd just like to open the floor to any questions. I think there's something that came up in the chat. Lola's asked, should all sickle patients have an annual nutritional assessment as part of their outpatient appointment? And will this be an area of development in the field of nutrition?
So I remember maybe 35 years ago when we were first asked to help with patients with cystic fibrosis at a time when their life expectancy really wasn't very good, where the major focus of care was on their respiratory problems and virtually none on their gastrointestinal problems or their nutritional problems, which obviously of itself had an impact upon their respiratory well-being. And we introduced with the clinicians in Southampton a regular MOT, which included characterization of their nutritional status. And that still exists, and it's used, and it's been very effective, not only in supporting the families and the children, and now the adults, but in exposing issues of really quite considerable importance. So that I think we were the first to identify and encourage the need for vitamin A supplements in children because they have fat-soluble vitamin malabsorption, and that gives rise to poor mucus, and poor mucus gives problems in respiratory tract and so on and so forth. And that was good, but in the way of health professionals, if a little bit of good is good, then even more would be better. And so the enthusiasm got so much that they gave more and more, and particularly they gave more because the plasma marker for vitamin A didn't appear to respond. And the plasma marker for vitamin A didn't really respond because they still had an inflammatory process going on, and it's a negative acute phase reactant. And so there are a number of children who developed a measure of vitamin A toxicity. So yes, I think every child should have an MOT. I think we did it annually for the cystic fibrosis children. I think there's a judgment that needs to assess how frequently, depending upon the child's well-being. If the child is well, maybe once a year. If the child isn't sick, then isn't well, then more frequently related to the sickness. But there's no doubt in my mind that an ongoing assessment of the child's nutritional well-being has to be every bit as important to the care of the child as the other aspects that have greater focus and attention.
But I would say that would also apply to the adults as well, wouldn't it? Not just the children, yeah. Because it's so important, nutrition, in improving outcomes in patients with sickle cell or with any condition, really.
So what I don't know is whether you already do this. I mean, I presume that you probably did it, and some places did it very, very well. Some places maybe needed a little hand-holding and encouragement, but it would be, I think, very, given the reality, given that you have neonatal screening, everybody should be followed from birth, and that information should be part of a national database. And that database should be used as a guide for developing policy and care options.
Thank you. There's a comment from, question from, I hope I've said this correctly, so apologies if I'm wrong, Tuli. What should we suggest our patients should eat other than the general? In other words, in the absence of information, any sensible advice?
patients who are otherwise well should eat a healthy diet, engage in physical activity, and drink water alongside government advice for healthy living. It is remarkable how few people actually adhere to healthy guidelines. If everybody were to adhere to healthy guidelines and some individuals did not do well, then that is a very useful starting point for better understanding what is the nature of the problem that they have. But if you don't start from that position, then it is really quite difficult. And so I think that is, you start off with eating healthily. I think any question of what I might characterize as a therapeutic intervention is when that doesn't work, and that is of itself an indication of the need to consider more carefully.
I've got a couple of hands up, and then there was another question in the chat. So, Sarah?
Yeah, hi. I think all of us doing annual reviews, sorry, a haematology consultant in Coventry, I think all of us doing annual reviews are probably trying our best to do some sort of nutritional assessment. And certainly when I get a new patient, I do try and find out what their diet is like. I get a lot of students in Coventry, so the first question is, are you living entirely on chips and takeaway, or is there any nutritional value? And we definitely see those patients who are cooking for themselves, who are eating fish, who are eating veg, kind of generally seem to be healthier than the chip eating, non-variety patients. But while we can give healthy eating advice, where we struggle, and I suspect it's a funding thing and probably is everywhere, is with any dietetic support for our patients that really are genuinely struggling and kind of losing weight despite doing the best that they can. We've recently lost our haematology specialist dietitian because she was being pulled into other cancer areas, and she didn't really have any funding for red cells but saw them anyway. There really is very little funding for non-malignant dietetic support around, as far as I can work out. So I think this is going to be another thing where we have to push for equity of care for our patients.
Yes, I think you're quite correct in identifying that there is the provision of dietetic support is really in all areas is less than most health professionals would wish. And I'm sure that there are all sorts of groups that are pressing for greater emphasis in those areas, and it is competitive between the different areas as to what happens. I think given that situation, it is reasonable to reflect on whether or not there are things that you might be able to do that short of full dietetic advice. In my book, patients that are sufficiently unwell to need nutritional support or nutritional advice, and maybe I differentiate nutritional support from dietetic support in this respect. There is very well established guidance from the World Health Organization on how to manage individuals who are undernourished to varying degrees. And that is guidance that is developed for delivery in the most challenged communities with least resources, and it works very well. And I don't know whether you ever watch the television, but you don't have to watch the television for very long to see pictures of children in Yemen or where else. And the same principles that are adopted for feeding those children are the principles that we adopt across the board in clinical care. And there is maybe more that can be done according to an appropriate algorithm in order to seek to bring about improvement when formal dietetic support is limiting. I don't know whether the Sickle Cell Network has reflected on that or considered that, but if they haven't, then it may be something that is worth considering.
Certainly at Imperial, we do have a dietitian for our ward patients, and we have allied health professionals, MDT, on a Wednesday of the inpatients, so with the occupational therapists, physiotherapists and dietitians. So that is all included there, actually. So that's because, it astonishes me that, how important nutrition is, and then you just see the hospital food that people get given, and it's just quite shocking, really. You're just like, how are they supposed to get better if you're giving them food like this?
So I would make the point again that following a stressful experience, nutrients are lost from the body. And the same diet that was adequate before the stress may no longer be adequate following the stress, and it may require a period of more intensive support to make good those losses in order for the individual to have a reasonable chance to hold their own on the diet that they had before. It used to be captured within the idea of convalescence and recovery, but that sort of sense of special needs following a stressful exposure from the nutritional and dietetic point of view is less evident. And I also would emphasize the importance of physical activity for enabling or providing balance within the internal nutritional milieu. And it's not a nice to, it's really a very important consideration within the whole metabolic set. In fact, it is a major determinant of the metabolic set and gives individuals the ability to do things for themselves. And I think that those two considerations are often not as well appreciated as they might be within the framework of care options.
Oh gosh, apologies again if I mispronounce your name. Anianwu has asked, what is the link with nutrition and pica in sickle cell disease?
I don't know that I can answer the question, and clearly there is there has always been the ongoing debate as to the extent to which pica is a psychological disease that gives rise to nutritional problems, or a nutritional disorder that gives rise to psychological problems. I have to say that in my experience, and this goes generally, there's such a range of psychological changes that take place with nutritional problems that it's not possible to assess a patient's psychological well-being unless their nutritional well-being has been addressed first. And this goes across the whole range of healthcare and includes patients with more extreme eating disorders. But the psychological function is set and modulated like any other tissue by the nutritional environment, and without excluding the possibility of important psychological causes, correcting the nutritional well-being excludes a series of considerations, and a number of patients will improve and get better in that respect alone. Not all, but many will. So, and I guess it depends upon the context and the situation in which you're operating. But again, I think it's part of this this nexus of the effects of the stress response becoming cyclical in a negative spiral unless they're addressed, and you have to break that negative cycle in order to move in an appropriate direction.
I mean, I've seen it with iron deficiency, obviously, but you see it even in iron replete sickle cell patients as well. Lola, you had your hand up, or is that an old hand or a new one?
No, I just wanted, I know that, Alan, you mentioned something about hydroxyurea and nutrition. I just wanted you to expand on that a little bit. Are you saying that, you know, we need to look at the nutritional status of the patients if we put, because I'm just thinking in terms of a lot of our children now are put on hydroxyurea routinely as a preventive medication. And I just wonder whether we should be looking at hydroxyurea in relation to the nutritional values that they come with before start on hydroxyurea and along the way.
So I do not feel very competent to talk about this, Lola, because I know virtually nothing about hydroxyurea, but my reading leads me to understand that, first of all, its mechanism of action is not well understood, that its effectiveness is variable, and it works very well in some, but not by any means in all. And of the described effects of hydroxyurea is an important effect upon redox challenge, and that it improves the redox environment of the individual, and it's argued or suggested that that is one mechanism through which it might confer benefit. Now, what I have been talking about is that the fundamental redox set is profoundly related to the nutritional situation. And so my first question would be, in those situations where hydroxyurea is less effective, if it was supported by a better nutritional state, might it have better effect? And to what extent might the dose of hydroxyurea be less were the regulation and control of the redox state improved? I don't know the answer to those questions, but all that I can say is that those are obvious questions that the literature throws up, which I don't think have yet been answered. And I mean, part of the difficulty in the world is that, I mean, all pharmacological interventions are chemicals. All nutrients are chemicals. And so there is inevitably a relationship between the chemical handling of the pharmacological agent and the chemical environment that is set by nutrients against which they operate. And for all therapeutic interventions, there is modulation by the nutritional state and the nutritional well-being. How important that is and how much it matters will vary from situation to situation. But given the enthusiasm and the apparent benefit of hydroxyurea, I think it is worth asking the question in that way, because maybe that's a clue to help us better understand how we might manipulate the patient's well-being without using potentially strong therapeutic agents.
Thank you.
Are there any other questions? It's now 7 minutes past.
Is it Nicole, Sarah? Nicole?
Sarah, I think, is that an old hand or a new one, Sarah?
Sorry, it's an old hand.
Old hand. Well, I'd just like to say, Professor Jackson, then thank you so much for a very, very comprehensive talk. Lots of food for thought, pardon the pun, sorry. And and we're all going to go and make lots of healthy food and go and do lots of exercise to to keep well. Yeah. So
well, I would encourage you to come together and maybe do something. Nothing complicated, but something relatively simple but straightforward in terms of collecting data consistently so that you can look at the data and better understand the potential impact for your patients. I know it's very easy to say, I know it's much harder to do, but I do think it is doable and potentially quite important.
And I'm sure we can rely on your support for that, Alan.
Thanks very much, and have a lovely weekend, everybody. Take care.